induction of labor, because as we all know, in today's circumstances, there are many high risk pregnancies, there are pregnancies with comorbidities, there are a lot of social implications, and many other instances when induction of labor is a necessity in our clinical practice. And of course, we have had the age old practices of the mechanical methods of induction and the pharmacological methods of induction. But of course, whenever we have a new drug on the block, I think it always comes with a message that it must be better, or it must be having a few advantages over the previous methods we are using. And any number of methods we have, when it comes to the particular patient, I think we need to assess the patient, assess the Bishop score and the facilities available, and then choose the method of induction so that we can get a good outcome and the mother and baby are healthy following whichever method of induction we use. And the indications, I think we have to choose our indications very well before we start inducing the patient. And one tip I would like to say, a key point I would like to say is, do not induce in a hurry. Do not induce patients who are unfavorable, who have an unfavorable cervix, because very often we are seeing that many of our, very sadly, I'm sad to say that many of our practitioners, due to their own personal obligations, or they have to travel somewhere, or they have a function in the family, they try to accelerate the process of induction, though the woman is not yet ready for that, or her cervix is not yet ready for a favorable outcome. And we try to hurry up with the inductions, and sometimes we don't use the correct protocols for induction, we don't follow the partograms, and very often, sometimes the woman lands up with a operative delivery. So I think Dr. Ashwin is going to highlight on this. So selecting the patient for the right indication and choosing the right method at the right time is what is needed for a successful outcome of any induction of labor in any woman in any setting. And of course, as it coming to the social obligations we have, you can understand that in singly owned hospitals are available and we have our women waiting for us at that particular time. And if we want to go for a conference or a wedding or any social obligation, we are sometimes tied down to the woman's request that she should be delivered by us. So this is where I think, as Kasogians, I think now it is the day of group practice. So we need to tell our patient and her relatives that we will have a group of obstetricians in the particular town who will take over charge whenever the necessity arises. So there's no hurry for me to induce just because I have to go out. I can always tell them there's somebody else on call. We can wait up to 39 weeks. We can wait 40 plus weeks and then induce, provided there are no other obstetric complications for induction of labor. So I congratulate Dr. Shobha for choosing this very good topic. And this ProPress, which is going to be discussed by Dr. Ashwin, is of course been in the market for quite some time. And during the COVID times, I had to go to Dubai for my daughter's second delivery, and she was almost 40 weeks, and I think that time she was induced with the ProPress, and it was not available with us at that time, and even right now it is not available in these small towns. Because when I spoke to the pharma company, they told us that the logistics involved and the necessity of it maintaining the temperature. It is a heat labile product, and the temperature control is a handicap, I think, which Dr. Ashwin will be talking to us in his talk. Thank you very much, and I wish you all a good webinar on induction of labor and a happy, stressless weekend from tomorrow. Thank you.
Thank you, madam. Thank you, madam. Next, I want to introduce our another guest of honor, Dr. Nagaraj H, who is a patron of Kasoga and who is a great advisor to Kasoga. Dr. Nagaraj is there, sir?
Suguna sir has said he is not very, well disposed today. I think he is giving us his blessings. We must carry on. Thank you, Suguna. Please carry on.
Can you share the next slide of Dr. Vidya Tobi madam? I think even Vidya Tobi madam is traveling.
Yes. Yeah, we will take her message whenever she joins.
Yes.
So you can
next, can you put the slide of Dr. Durga Das Arsani? Arsana? he is our president-elect of Kasoga. Sir,
Yes, yes.
he's past treasurer of Kasoga. He's a president-elect of Kasoga, and he's a past
Enough.
of
They are all in
Kasoga.
Kasoga only.
Yes. Sir, can you tell us a few words about the induction of labor? And you are also, I think, the expert for our queries.
Yeah.
Yeah.
Good evening, everybody. At the outset, I congratulate Dr. Shobha Gudi for arranging such a beautiful webinar. It's an upcoming subject. As we all know, it is one of the upcoming things. It is one of the most widely used surgical technique in obstetrics. Next to, I think, cesarean section. As Dr. Bharti right now told correctly, so many comorbidities, so many medical problems coming up with the pregnancy, and we cannot take them to up to term 40th week. They do require a safer method of termination of the pregnancy after the period of viability, and there are n number of products available in the market, and today we have a novel product which is really doing a good job. Though I have not used it, I have heard a lot about that, and it's going to come up in a big way, provided the logistics are fulfilled. And I thank Dr. Ashwin Kakkar for joining us today to enlighten us. You are the master of this product. We want to hear from you, and so that we can all start using this product. With these few words, I congratulate once again Dr. Shobha Gudi and all the attendees today. Thank you very much.
Thank you, sir. Can you please share the slide of Dr. Rajeshri Palladi, madam? Dr. Rajeshri Palladi, madam, is our Secretary General of Kasoga. And she's also Dean on Research of KBN University. Madam, can you speak, tell us a few words about the induction of labor?
Yes, Suvita. Pranamams. Good evening. Everybody, and welcome to this wonderful program. More about the program labor, wherein the methods and the indications are going to be discussed extensively by the experts as well. I'm sure this webinar is going to give us a good practical experience, exposure from the masters and from the experts about the ways in which they are making the labor very good, happy ending, and most importantly, to try to reduce the incidence of cesarean section. That should be our ultimate motto. Very best wishes for the program, and over to you, Dr. Subhana.
Thank you, madam. Arun, can you share Dr. Shobha Gudi's madam slide, CV? Dr. Shobha Gudi, madam, is the convener of this webinar, and you all know she's an expert in contraception. She has done great work in contraception cover, and she's the professor and HOD of St. Philomena Hospital, Bangalore, and also she's a postgraduate teacher, and she has so many honors to her. This one. So, can you, madam, introduce Dr.
No, I
Ashwin
will. No, that the chairpersons will do. Our esteemed chairpersons are there, Suman and Kasturi. Both of them are professors. They will be introducing. I am currently, I just wanted to make myself known to Dr. Kakkar because I have not met him face to face. I'm really happy, Ashwin sir, that you were able to join today amidst your busy obstetric work. I'm really grateful for that. And our only wish is someday we can invite you to Kasoga in a physical CME or a conference so that we can interact with you face to face. That will be a great honor for us. So thank you for being here. At the outset, I must thank Dr. Jayaprada. Please mute yourself, Jayaprada. Yeah. So at the outset, let me thank the Kasoga body for encouraging me and constantly providing me opportunities to work for Kasoga. I'm very grateful to Hiramed sir, Nagraj sir, especially to my friend, dear friend, Bharti. It means so much to me that Bharti is also kind of now become a chairperson of FOXY committee. I wish that more leaders from Kasoga would come into FOXY to work because it is a very dynamic platform. I'm grateful to Dr. Vidya Tobi and Dr. Durgadas Sasrana for encouraging me, and also to Rajeshri for being such a good friend of mine. So today's topic is worth spending these 2 hours of deliberation, because it is not about learning what is induction of labor. I think everybody, every obstetrician knows what it is, but it is only to build up the courage to continue and to kind of see through the entire process, so that the woman gets the best chance for her, for a natural childbirth. Even though it is induced labor, when it ultimately happens, it equates to a normal delivery for her. By definition, it may not be for us, but for her, it will be a natural birth. Also, I think it's very, very important to have contemporary sense of what is happening, what is the evidence in support of the various pharmacological and the mechanical methods. So we thought that it will be a good thing to discuss, mainly to build up obstetric courage to see that we do the best for our patients. So back to you, Suguna and Shobha. Let me take this opportunity to thank both of you for agreeing to be here. I know both of you have had personal commitments today, but you agreed to be here to conduct this session. Thank you very much. As chairpersons, you are doing a great job. Thanks a lot.
Thank
Please
you so much,
continue
madam.
to say. Yeah.
Thank you so
Yes.
much, madam, for your introduction to the topic. And we are so grateful to you for organizing this webinar, which is a very, very important topic. I take this opportunity to welcome all the delegates also to this program. And also we have Dr. Kasturi Donimat madam who has joined, Dr. Ramlingappa sir who has joined, who are all stalwarts of Kasoga. We take this opportunity to welcome you all. And now I call upon Dr. Kasturi Donimat madam, who is the past president of Kasoga, to introduce the speaker and to chair the
One more
session.
chairperson is there.
Yeah,
And Dr.
first
Suman Reddy
introduce both
madam.
the chairpersons with the CV, then they
Yes,
will
ma'am.
introduce Dr. Ashwin. Yeah.
Yeah. And share the CV. So our first chairperson is Kasturi Donimat madam, who is the past president of Kasoga. She is also the past HOD of KIMS Hubli. And we have we welcome you, madam, to chair the session. Kasturi madam. And we have Dr. Suman Gaddi madam, who is the treasurer of Kasoga and also professor and HOD WIMS Ballari. Madam, we welcome you to today's session, and we welcome you to chair the session.
And introduce our speaker also.
Yes. Thank you, Shobha. Thank you, Suguna.
Thank you,
For
madam.
the
Thank
nice
you, madam.
introduction, and very happy to be a part of this. And special thanks to Dr. Shobha Gudi for conducting this webinar on such a nice topic. Actually, as everybody told, now there are so many things available for induction of labor. And hello, and we have the luminaries, so many experienced people putting their inputs that will really make a difference in our day-to-day practice. And with a good method of induction, we can really reduce the C-section rates. So we have very good experienced people like Dr. Ramlingappa and everybody who can give their very practical inputs for this. Now it's my present privilege to introduce Dr. Ashwin Kakkar, who is a practicing OB-GYN at Kalyan since 17 years at Vaishnavi Maternity Hospital, Kalyan, Maharashtra. And his special interest is in high-risk obstetrics, to minimize the number of interventions in pregnancy and childbirth, to follow evidence-based protocols and standard guidelines. Sir has done his degree from GS Medical College, KM, Mumbai, very prestigious institute, and worked in BL Nair Charitable Hospital, Mumbai, and received many awards, received Best Paper Award for presentation at AICOG, Bhubaneswar, and contribution to newer and safer methods for induction of labor, and received Best Paper Award for presentation at MOGS. It's a really pleasure to have Dr. Ashwin Kakkar, and we are very eager to hear on this topic. As I told you, there are so many new interventions coming. They will really help us to have to increase the vaginal delivery rate and reduce the C-section rates. Because in our time when we were students, I can remember only method we had was just stripping at the most laminaria tent and syntocinon. We didn't even have prostaglandins those days. So the every new molecule which is coming is really making a difference in the methods we induce. So very happy to hear from you, Dr. Ashwin. Over to you.
Thank
And
you
Dr.
so
Samal, your comments.
much. Is my screen visible?
Yes, sir.
First, let me thank Dr. Shobha for inviting me for this webinar. Actually, I'm not a person of webinars. I would like to be physical. I told madam, but she requested, so said, let me have a webinar also. Probably I'm speaking to all of you all who are teachers or, and I'm not neither an academician. I'm just a basic obstetrician practicing in a small city of Kalyan, which is 50 kilometers away from Mumbai. And I only practice obstetrics. I do not do any infertility, no laparoscopy, nothing. I only practice obstetrics. That's because I love obstetrics from the time I passed out from KM and I decided I want to be an obstetrician. My city lacks a lot of obstetric facilities when I started practice way back in 20 years back. But today, at least, I'm able to serve every corner of the society, every woman who needs a labor in a dignified manner is what my aim was, and that's what I'm able to do. Way back in 2014, I realized my seizure rates are going more than 20-25% for a primary gravidas, and that was wrong. And then we had this newer drug coming in 2016, that is the Dinoprostol vaginal insert. And then I started using this, and over the period of next 20-25 minutes, I'll show you how it has benefited my patient and my practice also. Are women really going in labor? I think no. We are not seeing any more spontaneous labors. We have a lot of women requiring induction of labor. Spontaneity of labor is now a rarity. Even your second gravidas and third gravidas do not come in spontaneous labor. In my practice, I see around 30-40% women who require induction of labor. We are liberal in induction and patients do not on their dates. That's one more reason why we are using more and more women. So in this course of time, we'll see who to induce, when to induce, why to induce, and how to. Overall, is the nature taking too long? Yes, definitely the nature is also taking too long for women to deliver. I rarely see a woman primary gravida 37 weeks with engaged head and she comes to spontaneous labor. When I started my practice 20 years back, I would see definitely a lot of women in spontaneous labor. But today, either she starts leaking with the nose closed or she just does go in labor to the dates at first. And even if you want to convince them to wait up to 40, 40.5, then they are not very comfortable. Doctor, why don't you deliver because the date has crossed? They all know that the baby may cause meconium. So patients are insisting for induction. That's one more reason why induction rates are going on. So what's the right time to induce? We'll get to that.
Dr. Kakkar, sorry for the interruption. There are some messages saying that your volume is a bit low. So kindly increase it. Yeah.
So what is the so what is the most important factor when we decide about induction of labor is the Bishop's score. Any induction without judging the bishops is a real failure. According to bishops, a score of maximum score is 13. A score of 9 or more, induction is always successful. A score of 4 or less, failed inductions are very common. And in such cases, mechanical methods of induction should be considered. So the most important factor for induction to be successful is your Bishop's score. So unless the Bishop's is good, you will never have a successful induction. So what is induction of labor? Induction of labor is initiation of contractions in a pregnant woman who is not in labor to help her achieve a vaginal birth within 24 to 48 hours. So here, the aim of induction of labor is to achieve a vaginal birth and the time specified is in 24 to 48 hours. It is indicated. What's the indication of induction? Where continuation of pregnancy would mean that the risk to the mother or fetus outweigh the benefits from further observation. So anything in induction, wherever you feel this pregnancy continuing further will be a harm to the baby or the mother, can be a cause for induction of labor. What are the undesirable outcomes? These have been clearly designed by the Cochrane as vaginal delivery not achieved within 24 hours, uterine hypostimulation with fetal heartbeat changes, a requirement for a cesarean section, serious neonatal morbidity or parental death, and maternal morbidity or death. As I said, any method, any reason what I feel other patient is convinced that she needs an induction of labor can today be a cause of induction of labor. The most common indications will be your post-dated pregnancies, your gestational diabetes, the pregnancy-induced hypertension, intrauterine fetal death, and IUGR patients. How do we monitor patients in case of post? What in routine practice, I generally do the first per-vaginal examination only at 40.1 weeks. I do not generally interfere with the patient's examinations with 40 weeks. So once she's crossed her day, we will do her first digital examination. And if she's favorable, we ask her to wait because most of the patients will go in spontaneously within 40 hours. And if she doesn't give labor in 40 hours, then we plan for induction of labor, that is between 40.1 to 40.5 weeks. I've set a deadline of 40.5 weeks. Beyond 40.5 weeks, we generally do not. We ask the patient to monitor her daily fetal kick count. That's the best method for fetal well-being. And explaining to the patient that please keep a watch on the fetal movement post meals. We are very particular telling them that we don't, most of the patients in their free time would always go onto the mobile and start seeing some videos, and that is where they base a fetal movement. So I insist that you keep your phone away from you. We ask them to follow every alternate day, and we do a stress test and a biophysical profile or a color Doppler at 40 weeks is what I ask all my patients if they go post-dated with an unfavorable service. If I have a favorable service, I may not get a color Doppler done. But if an unfavorable service for me to decide to wait for the 40.5 or up to 40 weeks, I would require color Doppler. What are the recommendations? Elective inductions before 41 weeks without any medical indication and unfavorable service is not desirable for physician comfort. I think Dr. Bharti very well cleared that we are inducing more and more patients for our comfort, which is a strict no. Non-indicated elective inductions before 41 weeks of gestation are associated with increased risk of cesarean. Inducing labor before 39 weeks in absence of medical indication result in increased NICU admissions. However, in developed countries, almost 25% of deliveries at term now involve induction of labor. In developing countries, the rates are generally low, but in some settings, that can be as high as observed in the developed countries. I think even in India, we are around 25 to 30% of the deliveries requiring induction of labor. What are the prerequisites? Once I've decided to induce my patient, the most important factor is go to the first dating scan. If your 7 weeks ultrasound has also shown any discrepancy of 7 to 10 days, I would like to give an advantage to the women that let's wait for some more days, provided her doctor's studies are normal. So if I have a patient whose dates are, maybe showing 7 or 8 days of differences in the EDD and the US EDD, your ultrasound EDD, we would ask you to wait for some more days. All your induction of labor should be strictly cephalic presentations. You can induce leach in a multigravida, but again, that's an option which you and your patient can decide if it is not indicated. Your induction should only be vortex presentations. Station, as I said, I would not really bother. It is not very common nowadays. We can also induce patients with floating head. Cervical ripeness, I already told, Bishop's is the most important factor, and definitely your parity. If the patient is multiparous, the chances of her getting a good result with induction is much better. What are the contraindications? I think we will not induce, we all know these, a transverse lie or a placenta previa, active genital herpes, and a previous scarred uterus are strictly a contraindication to induction of labor. What is the time required for induction of labor? When to induce patients? Now, these are some guidelines. Routine induction at 41 weeks of gestation does not increase the cesarean delivery rate and may decrease it without negatively affecting pregnancy morbidity or mortality. In fact, both the women and benefit from the induction of labor in a well-dated, low-risk pregnancy at 41 weeks. It's very clear at 40 weeks in a well-dated, low-risk pregnancy associated with low adverse outcome. This was 1790 at 40 weeks with few benefits, and there are multiple reasons not to allow pregnancy to progress beyond 42 weeks. However, elective induction, as Madam already said, is increasingly being used as a management strategy. What are the general principles? If induction of labor should be performed, there should be a clear medical indication for it and the expected benefit outweighs potential harms. It has to be a very, very clear indicated that why is this induction required. It's a compulsion in applying the recommendations. Consideration must be given to the actual condition, wishes, and preferences of each woman. A consent before induction of labor is a mandatory form. And I quite often see in my practice that patients refuse induction of labor. No, we are not willing for it. That's because some poor or someone has not had a good experience and they refuse induction of labor. I still try to motivate them. Yes, but in my practice, I may say at least 10 or 15 women in every month that who refuse induction of labor, that no, we are not willing for induction of labor. In that case, we are left with no option. Try to convince them, otherwise it has to be for cesarean section. A consent for induction is a must. Induction of labor should be performed with caution since the procedure carries the risk of uterine hypostimulation and rupture also. Fetal distress is quite common. Wherever induction of labor is carried out, facilities should be available for assessing maternal and fetal well-being. Women receiving oxytocin, misoprostol, or other prostaglandins should never be left unattended. Failed induction does not necessarily mean a cesarean section. Wherever induction of labor should be carried out, facilities of cesarean section should be always available. What are the methods of induction of labor? Various methods are available. The mechanical, the stripping of membrane, the pharmaceutical method. Castor oil, which was very much available, as I am strictly against it and I never prescribe it. Membrane stripping. It's very uncomfortable patient, but it's a very important role in induction of labor. It involves insertion of a digit post the cervical os, followed by 3 circumferential passes of the digit, causing separation of membranes from the lower uterine segment. And in cases where stripping is not possible, unfavorable service, cervical massage between forefinger and middle finger should be attempted. Please warn the patient of pain, bleeding, and anxiety. Discharge post-procedure to anxiety. I think most of your patients after a stripping of membrane should go in labor in the next 24 to 48 hours. I think misoprostol is a wonderful drug. It's available the way you want to use it. It's available in oral, sublingual, and vaginal. It is the drug, recommended for induction and augmentation of labor also. It is licensed for labor induction in India. It is sanctioned for WHO now. Now they've changed in 2020. Initially, it was recommended as 25 microgram every 4 hourly and maximum of 4 doses. However, now they have changed it to 25 microgram every 2 hours and maximum of 8 doses. How does the dinoprostone work? The dinoprostone mechanism of action is cervical wrapping. It also helps in cervical dilation. It promotes uterine contractions and a half-life of 2.5 minutes. What are the other methods? I think I already spoke about castor oil, having exercises. We can always be telling to a patient to use the other methods, but they are not 100%. So now coming to what is the recommendation. Intravaginal pessary, 1 cycle of controlled release intravaginal pessary, that is 1 dose over 24 hours, is the most preferred method of induction unless it is controlled. It is very safe and effective. It is controlled and sustained release. I think this is the most important part of the drug. It is user-friendly. It helps reduce the need of oxytocin augmentation. Patients are very comfortable and the presence of retrieval system. That is, control of the degree of cervical wrapping and drug administration can be stopped by the insert withdrawal at any time. The sustained release pattern and the withdrawal of the drug makes it the most favorable drug. How does it look like? It's a dinoprostol vaginal pessary. It's a 10 milligram reservoir. It's an intravaginal insert and a controlled release of 0.3 milligram per hour. What is an indication? It is only and only for initiation and continuation of cervical wrapping in a patient at or near term in whom there is a medical or obstetrical indication for induction of labor. Believe me, if the patient is in labor or says that she has some pain or discharge, do not use the pessary. It is only for initiation of labor, never for augmentation of labor. How is it used? 1 pessary vaginal delivery system is inserted high into the posterior vaginal fornix. The vaginal delivery should be removed after 24 hours, irrespective of whether cervical wrapping has been achieved or not. How does it look like? It's a thin, oblong, semi-opaque hydrogel delivery device. Size is 3 by 10 by 0.8 centimeter. It's a 10 milligram dinopercent dispersed in the matrix, and the retrieval is pouch plus withdrawal tape is 30 centimeter long. The storage is the most important part. It's stored between -10 to -25. It can be in ordinary hospital. You can store it in the freezer of your refrigerator. It's perfectly okay. How is it administered? Hold the dinopercent vaginal insert firmly between the index and the middle fingers. Introduce into the vagina assisted by a small amount of aqueous gel. Position behind the posterior vaginal fornix. Position the insert transversely to remain in situ. It has to be in a transverse insertion, never vertical. How do you remove it? Gently pull the retrieval cord. What are the indications for removal is once 24 hours have passed, the patient has gone in active labor, uterine hypostimulation or rupture of membranes, and any adverse effect. I think if the patient has a spontaneous rupture of membrane, or even if you have done an ERM, you can leave it for half an hour to 1 hour, and after that, please remove it. Not beyond that. It is a long chain of polyethylene oxide are cross-linked to produce a polymer. Dinoproston is held in the hydrogel until the product becomes moistened upon administration. Approximately 0.3 milligram of dinoproston released every hour over a period of 24 hours. What is the advantage over the gels as well as the insert? The insert is a single dose. The gel may require multiple doses. It is very easy to insert. The gel may require the same speculum and may spill out. It is very easy to remove, reliable and quick, whereas the gel is very difficult to remove. If the patient goes in hyperstimulation, the removal is extremely difficult. And the patients are very comfortable. You can ask them to move out in 20 to 30 minutes after the incision. What are the inductions in special circumstances? We have a refractory induction. The patient is refractory when there is no change in cervical score 24 hours post-induction or failure to go in active labor. In such cases, it is advisable to wait for 24 hours before reinitiating induction of labor with a prostaglandin again, or Foley's catheter may be tried. But in our private practice, I think no patient would insist to wait for so long. If you have tried for 24 hours, the patient has got not into labor, I think the relatives will always insist for an LSA. But I do try to convince them that we can wait on for some more time. Previous LSS in a patient with an uncomplicated previous cesarean and with an uncomplicated current pregnancy at term carries 60 to 70 chances of VBAC. This is very clear. Her previous section should be uncomplicated. She should have no complications in this pregnancy. She has a chance of 60% vaginal delivery. However, inductions on case of previous LSS carries a higher risk of rupture as compared to patient in spontaneous labor. Foley's induction and oxytocin are only options available for previous LSS. No other drug can be used. Outpatient induction is a strict no. No patient should be given any drug at home basis. I think the risk of inductions are very clear. You may not achieve labor. The patient may require cesarean sections. The operative rate chances also increases. You have fetal distress with tachysystole. Choreomyelitis, yes, definitely. Cord prolapse again if you have a high floating head with polyhydramnios. Inadvertent delivery of a preterm infant in the case of inadequate dating. So I already emphasized that always go back to your first ultrasound before you decide induction of labor, and uterine rupture in scarred and unscarred uteruses. So is one single drug recommended for all your patients? No, definitely not. Every patient, depending on the bishop's parity, would require different method of induction of labor. I have a primary gravida at 41 weeks with a long tubular cervix, still not in labor, no other high risk factors, you will require mechanical coming. You have a second gravida who's 41 weeks, 2 to 3 centimeter dilated, not doing labor, your mesoprostol will go. You have a patient who's a primary gravida, gestational diabetic, one finger mid-post, very well effaced cervix, ProPace will work. So this is how every patient will require a different method of induction depending on the bishop's parity and multiple reasons. One other drug which I love the most, but it is sadly not approved in our country. It is a 19 non-steroid with potent competitive anti-progesterone and significant anti-reproductive activity as well as anti-androgen activity. It's the most ideal agent for cervical wrapping dose of 200 milligram across all gestation age. It is only approved for use in case of IUD. Now, if in what I do in my routine practice is, if I have a patient at 40.5 weeks, approximately that a low risk primary gravida, approximate a fetal weight around 3.3, 3.4, not more than that, a very bad cervix, I advise them to take a 200 microgram of mifepristone. Suppose it's a Monday today, I ask her to take 48 hours prior to initiation of labor. Call them after 48 hours and then try the insert or whatever other method. I think it works wonder. It works wonder. But the problem is that it is only at the risk of me and my patient that have decided to use this drug. This drug does not hold valid for in our country to be used on live babies for induction of labor. But what I tell my patients is in Marathi की तुमच्यासाठी वापरतोय म्हणजे if I'm giving any drug for you which is going to help you achieve a vaginal it is only and only for you. Though the drug has no side effect, your complications of post-dated pregnancy, please do not, feel that it is because of the drug. So we offer them, we take a consent from them separately that they are willing for the misoprostol trial. And I have rarely see a patient not going in labor with mifepristone. Yes, I want the societies to go ahead, argue with the government to get this drug legalized for use in India for induction of labor. I think we would achieve a good vaginal delay if that was allowed to be used for all our patients. I already said about the insert that it is very safe and effective. It has a control release pattern. It's a single dose with visual examinations. Reduced for oxytocin augmentation is also reduced. Patients are very comfortable and drug administration can be stopped at any time. That's the most important. Hook cervical balloon or the Foley's balloon, I think doesn't make any difference. I think Foley's is very much nice and you can use it in case of where you have a very bad cervix. Now we simultaneously try our patient with Foley's and with the Propes insert at one particular time. It doesn't really work very well, but your patients with an absolutely bad cervix where they have refused for mifepristone also, we try Foley's and the insert at times. Coming to my own experiences, a very short thing. This is the number of deliveries what I'm having in my hospital. We around have 4,000 confinements every year. My section rate is around 39%. This is the inclusive of all the patients, or the previous LSS and the high risk patients. However, my primary LSS rate is now down to almost 14%. We try to see that our primary LSS rate does not go beyond 14 to 18%. We had total number of deliveries in over last 7 years. We calculated around 20,000 till 27,000 deliveries we had. LSS rate was at 39%. However, the percentage of primary LSS never exceeded beyond 13%. Out of this, 12% of the patients we used where the insert was used. Overall, till March 2024, we had around 2,500 inserts being used. The overall cesarean section rate with Propes till date has been only 23%. That means I could achieve vaginal almost 77% of the patients. Why would some women not go in labor? I think the biggest advantage with the insert is that your patient will go in labor. She may deliver, she may not deliver something just out of question, but she will definitely go in labor. What we found is that patients requiring LSS had heavier weight babies. Their baby weight was around 3.3 or 3.4 kilos. If the baby weight was more, the success of vaginal delivery was much lower. Do we are using Propes for induction of in case of premature rupture memories? Yes, we do use in case of premature rupture memories also, where the cervix is very unfavorable and the success is almost the same. 23% would require LSS, rest all would deliver vaginally. I think I've already mentioned that. This is a very small study which we did when we started the change from the misoprostol tablet to the tape. We said let's analyze our own data, and when we analyzed it, we presented to the AISOG 2018 at Bhubaneswar, for which we were awarded the Best Paper Award. I'll just come to the results very quickly fast. The rest everything remaining same. When I was using the tablet only, my LSS rate was almost 47%. And when I started using the tape, my LSS rate in case of induction of labor came down to 27%. So I think achieving a vaginal rate of 73% of women in the induction of labor was a great achievement what I could do. And being very, the drug, the best part of the drug is its reversible action. I've already mentioned about the advantage of the insert. Coming to the most important part, that is significant difference in increase in number of vaginal deliveries and decreased cesarean sections was noted after use of controlled release dinoprostol vaginal insert. Now coming establishment of active labor was almost all patients in dinoprostol group, whereas failed inductions were very common in the misoprostol group. Coming to the few NST patterns, which would scare, but then that is the advantage of the reversible action of it. This is an elderly primary with a full-term patient at 38 weeks with gestational diabetes. We introduced her. This was her NST was okay, at a stress test was okay. She had this deceleration that after 4 hours, after 6 hours of the PROPES, and we removed the PROPES. Her pattern is back to me. She delivered absolutely fine. A 3.2 kilos baby after 7 hours of removal of the knee. A second patient, this is we induced her at 41 weeks. This is fine. She had this low baseline, almost 90, 100 decelerations. Here we missed that she had gone in active liver at almost 7 centimeters in the PV, and she was 7 to 8 centimeter dilated. We removed the PROPES and everything was fine. She delivered a normal baby. This is one very low risk primary gravida, only with an IUSR and severe oligohydramnios plus. An admission test was fine. We induced her at 1:06 in the morning. She had back distress in the sports. We removed the PROPES. The next baseline is absolutely fine. Anesthesia is reassuring and definitely wait on this patient. She delivered normally. Gravida, we induced at 37 weeks. She came with rupture of the membranes, and I thought this is a cord collapse. We did a full examination again. She was fine. We removed the anesthesia. She delivered normally. So this is the data over many years that my success with PROPES has always been similar. Around 23 to 25% is the only LSA state, and 25% is the vaginal delivery. Thank you so much. This is all what I had to say. The session is now open for questions. Thank you.
Chairpersons, can you?
Yes. Good evening, one and all. Of course, Dr. Kakkar given an overall view of the intravaginal PGE2 vaginal pessary. Very nice presentation, sir. And of course, one thing I would like to tell that after the advent of prostaglandins, the success rate of induction of labor, of course, has increased, what I personally feel. And earlier we used to have this Primipros tablets, where it used to give very good results. And now it is not available, probably. And now, of course, my personal experience with Semi-Prime gel is too good. Of course, I have to just start using this intravaginal PG to vaginal pessary and see the results. I have no experience with this vaginal pessary, sir. Anyway, very good presentation, and of course, it is encouraging to use this mode of induction. And over to Dr. Shobha Goody. Thank you, Dr. Shobha Goody. The topic is of course very good, and I'm sure we'll have a lot of discussions now with your interactions.
So one question: what is the cost of this pessary? One pessary?
It's around 2,500 rupees, madam.
It can be used in PRM also, sir?
Yes, madam, definitely.
That is an advantage.
Yeah, that is what. Dr. Kakkar, I just wanted to know, do you have any specific contraindications, or it is quite universal, this drug?
Universal.
So that is a very heartening thing to note, that hardly any case where you can't say that you cannot use, right? Everywhere it is. Yeah. So the other thing is, which usually people commit mistakes, is one specific area, obstetricians, because they might confuse failed induction with failed ripening of cervix.
Madam, can I take a minute? I would just like to interrupt. I'm a bit traveling now, but I'll keep answering my questions, madam. Okay?
Yeah, sure.
Thank you.
Thank you. Yeah, so with that, I think we shall move ahead with the next session. And if the coordinators, Shobha and Suguna, can take forward and introduce the other panelists, we'll start the next session. Yes.
So the next section is the frequently asked questions on evidence-based practice in induction of labor. We have experts, Dr. Durgadas, Dr. Rajeshwari Pallade, who have already been introduced, and we have Dr. Ramalingappa and Dr. Asha Malapur. Can you share the CV, please? Dr. Ramalingappa is the former director of KIMS, Hubli. Sir is a very experienced practitioner. So, sir, you are welcome to our session. Sir, are you there?
Yeah, good evening, madam. Good evening. Thank you. Thank you for including me in this session.
Next, we have Dr. Asha Malapur, who is professor and HOD of Nijalingappa Medical College, Bagalkot.
Thank you. Thank you, Suguna. I'm here.
Yeah.
No need to go ahead.
Thank you, Asha. So there are questions we are putting to the experts in order as they are there. First Durgadas, Rajeshwari Madam, Ramalingappa and Asha Malapur, and also you can add in between. So the first question is, excuse me. So in your practice, sir, Dr. Durgadas, sir, which
Yes.
indication pose a specific challenge during induction of labor?
Yes. There are, good evening. At the outset, there are multiple indications. Of course, the first one is hypertensive disorders in pregnancy, diabetes in pregnancy, postdatism, IUGR, PROM, and n number of indications are there, which we routinely induce the mother around the appropriate required time, like 37, 38, 34 weeks, accordingly. The one indication which I want to stress here is about the maternal indication. At the maternal request, indication at the maternal request. This is coming up very drastically. There is no obstetric or a medical indication. Only for the sake of her convenience or our convenience, we are inducing the patient, which actually should not be done. Even RCOG, even our FOXI itself is not encouraging this induction at maternal request. Whereas ACOG and RCOG, they do favor regarding the induction at maternal request. Other indications routinely we do according to the risk, wherever the bottom line of the indications are whenever the risk of continuing the pregnancy outweighs the risk of the induction. When the beneficial benefits are more by induction rather than the risk of induction, we take up for induction. That's all.
Anyone wants to add? Experts?
Madam, especially among these previous cesarean, actually, previous cesarean, one cesarean, two cesarean, somehow really we face a lot of difficulty to take risk of rupture. So even in institute also nowadays, the young obstetrician, especially nobody will
want to take the risk.
Induce correct. Even, of course, in private is okay, but even in institute also, the induction comes when previous section to section. So always everybody will be hesitant. So even though
have you had any experience, Dr. Ramalingappa, of previous cesarean? Yeah,
previous section in private usually I don't But
no, in the institution. I'm interested with it.
Yeah, institute also, the chance of induction is very, very less, madam. So actually, what you do with our routine practice, we should change it. Admitting all previous section at 38, 39 weeks, we are admitting. And many times patients also not willing for feedback. So many times they come with mentally they prepared, they come for section only. So a lot of counseling has to be done. And I think we should change. So when patient comes in labor, many times they come active labor. That time you allow and they do deliver vaginally. So
absolutely,
problem is with us only. So we admit and
feedback is common.
So I think selectively So looking at the scar thickness, some baby weight, all parity. So sometime we can ask them not to admit early, maybe 38, 30 is my personal view. So now we are thinking of changing the
Waiting
policy.
a little bit and then offering
madam,
mechanical method. Do you think a previous single known scar, a mechanical method can give us some?
Yeah, madam.
Provided the
Definitely.
previous indication was something like fetal distress or
Yeah,
breach or something.
non-recurrent indications.
Yeah,
so
correct.
definitely police induction, it works better. I think we are trying, but what literature tells and what Western literature tells 60-70%. So that much is very difficult.
Yeah,
maybe
correct,
5-10%. We are having successful results.
Well, I think somewhere the obstetrician loses courage
Yeah,
and the team is not ready to take the risk.
Yeah.
So
And patient also, madam.
probably, as Bharti said, if there is a team practice, then we can give courage to each other. I just want to know from any of the other experts, you know, this what is their experience, the incidence of VBAC following induction? Is it better when the woman would have had labor earlier? It is easier to get her into labor. And, you know, a single insertion of Foley's catheter may be useful before planning for a cesarean section. If they had come in labor and then the section was done in the previous time, yeah.
So in the institute, we are trying to encourage our postgraduates to, go for VBAC, because there would be round the clock supervision and then one-to-one surveillance of this patient. So our motto now is to see that we encourage more of our patients in the institute and also in the private practice also, unless we have a very good, backup, and do give them a trial of labor, having everything in hand, so that at least, there is a contention for the patient and for the doctors that we have done our trial with very good attempt. And some of the cases have really responded very well, provided the strict regulations and adherence to the guidelines have been taken care of. And definitely assessment of the scar is very, very important when we choose to decide to induce the patients. And definitely the mechanical dilatation by using the Foley's catheter has given a very, very safe and secure, with less side effects to the baby and to the mother.
So I think we'll go to the next question. Madam, Dr. Rajeshwari Palladi, madam, what are the prerequisites and what contraindication you rule out prior to induction of labor?
Well, when we make a choice of induction of labor, it's that we have put the kettle on boil and that she has to deliver. It's a matter of time, maybe 24 or 48 hours, but then we have taken a conscious decision that she is going for delivery. So being with the preparedness to see that all the criteria are fit in, all the, values are met with, and most importantly, to see that the period of gestation is very well established. Starting with the written informed consent and explaining to the patient and the attenders that this is what we are going to do, and that there is a 60%, 50 to 60% of chance that she may go in for good progress of labor and then we may end up with normal vaginal delivery. But there are also certain risks involved, either in terms of, failed induction, which we'll discuss later, or maybe the, the complications for the mother and the fetus, which have to be categorically stated very well. And before we try and plan for induction of the labor, all the requisites of the mother, the maternal indications, contraindications are looked into, and also the fetal well-being by doing an admission NST test to see that there is no deceleration or, there is no there's no fetal distress. And then to rule out any contraindications, all the factors to be taken into consideration, that is the passage, the passenger, and the power. Now, we definitely have to establish that there is no cephalopelvic disproportion or there is no fetopelvic disproportion. There shouldn't be any vasa previa. There shouldn't be any malposition, malpresentation, transverse lie or oblique lies as such. And then the power, like when the uterus is contracting, ensure that she doesn't have any scar. That is the unfavorable scars like the myomectomy scars or the classical cesarean scars. So a thorough documentation of the history of any surgical history or medical history has to be done. And then the baby, definitely if it is above 3.5 kg or you estimate that there is a hydramnios or there is a possibility that this may fail, then definitely the chance or the margin of having a success of your induction may fail. So try to establish all the three factors, that is the passage, the passenger, and the power. And after ensuring that, have the assessment, that is the Bishop scoring done. And it's better to go in for the modified Bishop score, which gives us a very practical approach to the case, rather than sticking on to the previous, like looking for the cervical dilatation, looking for the cervical effacement, and the station of the head. The other two parameters, like, looking for the consistency of the cervix or looking for the position, whether it is posterior or anterior, is not going to matter much. In addition, we can add other two factors, like add +1 if she has had a previous normal vaginal delivery, and if there is a preeclampsia. So these are the factors which will add on to give a favorable outcome. And you can subtract 1 if there is a postdated pregnancy, if she's a nulliparous and if there's history of PPRM. So proper assessment of a favorable Bishop score is mandatory, irrespective of the type of induction that we are going to do, be it mechanical or be it, by medical pharmacological methods. And this will help us to have a better outcome in the success of the induction of the methods. Now, contraindications, what we have, definite contraindications are CPD, definitely. And if there is a vasoprevia, which we have diagnosed by the ultrasound, and presence of infection in the mother, like if we have a herpes simplex viral infection, or, there are other infections in the vagina, where it would generally be a contraindication for even delivery. So also for induction of the labor. Now, previous classical cesarean, definitely no. We should not be attempting or taking the risk of having an induction of labor. So these are the contraindications, along with the fetal parameters like fetal well-being, etc., that will help us to know whether we are going to have a safe transit of labor. And in a myomectomy, we have to be very cautious and sure if the scar was involving into the myometrium, and also the duration of the pregnancy after the myomectomy. Like if it is within 6 months or so, then definitely it would be a weak scar. So also for the previous cesarean section, the ideal, the spacing bit to try for a VBAC after the last cesarean, minimum of 18 months. I think that very much comprises about the indications and the contraindications of how we are going to judge and pick up the patient for the trial of labor.
Oh, I think myomectomy, you meant endometrium, if it has entered into the treatment. Yeah, correct. Okay. Yeah, carry on, Suguna. Yeah.
Sir, Dr. Ramalingappa, sir?
Yes, ma'am.
So, do you have any specific consent for this induction of labor? Madam was telling about the consent. Any specific consent is there, sir?
Yeah, madam. And there is a format, consent form prepared by our Foxy itself. So there is mentioned what is the indication, what are the contraindication, what is the successful rate, and any complications. So all those things will be mentioned in the consent form. And patient as well as the attendant will be signing, and also the consultant also will be assigning the consent form.
Yeah, I think that's a very useful input you have given, Dr. Ramalingappa, that Foxy website. I think practitioners should get used to accessing that, and there are consent forms which are available there for almost every situation, obstetric and gynec, and they have been laboriously prepared by Dr. M.C. Patel and and his team. But I must also add that when Dr. Kasturi Donimat was the president, I think she is there. Kasturi, you are still there. And that time she had made the effort of getting this translated, and so that our patients who cannot read English can read only Kannada, they will be able to sign. Then it becomes a very informed consent, So I think, Kasturi, you must take the credit for that. Yeah.
Actually, Foxy, 2018, they have devised this consent form. Along with the consent form, there is a checklist also, madam. Checklist and also the patient information sheet also is there. So there also procedure will be explained and in short about indications and about failed index. All those things are there. I think it's better if it's in the local language.
We should, correct. We should download all that and keep it in the OPD, all practitioners, because I think these are tools which will help you not only medico-legally, but also in providing quality service to your patients. Because today, patients are very well informed. Don't you agree, Dr. Durgadas? You get very well informed patients today.
Yes. Routinely, what happens in practice, we counsel the patient and the attenders, telling that we are doing these things, and we don't take the written consent. That's where the pitfall is. We have the only thing Dr. Ramling Pawati was telling. We have to take a written consent. We have 3 sheets in this at Foxy GCPR. Yes. First is the checklist. Second is the information about the detailed things, and third is the consent, wherein both the patient as well as the surgeon signs. Yes, and very well translated by our dear Kasturi.
Yes.
Hello, sir.
Yes.
Hello.
Yeah, Asha.
Yeah. Presently, we are not taking as such this consent forms for IOL. It is taken generally only. So I feel that it is necessary to take a consent, which includes indication, risks, methods used, possibility of failure of induction, all those written factors in that. And as Ramlingappa sir said, we need to go ahead with those consent forms for each and every case of IOL.
So the next question is, Madam was talking about favorable cervix and Bishop score. So how important to Asha, Dr. Asha, how important is Bishop score, and which score will deter you or discourage you from induction, and how to overcome this? Asha Malapur? Asha?
Yeah, Asha, you have to open the account. Sorry.
No, but we can hear you.
Yeah.
You can? Can you hear me now?
Yes,
Yeah.
absolutely.
So Bishop score is really a good scoring system used to assess the readiness of the cervix for induction. So as Madam said, there are different components: cervical dilatation, cervical effacement, consistency, position, station. Okay. And predicting success again depends on the Bishop score. And we say that if it is more than 6, it is favorable cervix. And if it is less than 6, it is unfavorable cervix. So sometimes it is very difficult. There may not be progress. So overcome these things. So low Bishop score intervention is definitely needed for that. So I'll misoprostol, prostaglandins, and we go for mechanical methods like Foley's catheter. Some lesser Bishop score and like prostaglandins. So favorable cervix and unfavorable cervix are very, very important, especially challenges in unfavorable cases. Unfavorable cervix.
Anyone wants to add on this?
Yes, there is a modified, very well coined tool by Dr. Ashalata. There is a modification in this. Of late, we have started using, it has been started using transvaginal ultrasound to know the length of the cervix. So initially they used to tell about the effacement. Now they tell about the length of the cervix, and by using transvaginal ultrasound. After changing this technique from the digital technique to the ultrasound evaluation of the cervical length, there is a drastic improvement in the success rate of the induction. For example, I read in the literature that in the modified in the old Bishop score implementation, the success rate of around 23%, and whereas with using ultrasound, transvaginal ultrasound, the success rate was 62%. To that extent, the improvement has been seen. This is one thing. Second thing, as Dr. Rajesh has told very nicely about the plus and minus about the inclusion of the postdatism, inclusion of the preeclampsia, PROM, etc. That's all.
So
yes, madam. I also agree with sir. And we have also prepared SOP, and we are not going to give importance to the full Bishop score. Only we take a length of the cervix. So it's very common and practical. So less than 2.5 centimeter and more than 2.5 centimeter. So anything more than 2.5 we call it as unfavorable or unripe. Less than 2.5 usually favorable. So even there is a modified Lane score. So Lane score actually he excludes the position and consistency of the cervix. So only he takes a length of the cervix, then dilatation and station. So station also I think hardly it matters. So ultimately length is most important. Practically.
I think previously what we considered effacement of the cervix as one of the parameters is no longer applicable as such, because measuring the cervical length, and in all the circumstances, although the outcome is much better by doing the transvaginal ultrasound, but the ACOG guideline says that it may not be possible to apply the transvaginal ultrasound in all setup. So in those setup where the feasibility of the ultrasound is not there, the length of the cervix in centimeters is much more informative than doing the cervical length measurement in a busy setup, especially like we have in the government hospitals.
Okay, the next question is to Dr. Durga Das. We know Indian babies mature fast. So do you, in your practice, do you practice routine induction of labor at 39 weeks in low risk pregnancies, and discuss the evidence, pros and cons for this? Routine
Yes.
induction at 39 weeks.
Yes. Now, the first thing is why this rationale of induction at 39 weeks has come. It has come because of the two reasons. One is because of the increased complications after 39 weeks, like increased perinatal mortality, maternal problems, increased development of hypertension, and the placenta matures much more, and sudden stillbirths. All these occur in 40 weeks plus. So one of the rationale is to avoid the complications, better to induce routinely at 39 weeks, number one. Number two, as you told right now, the ethnical variation, like Indian babies mature much early. The 39 weeks is the 40 weeks for others. 39 weeks of Indian babies are 40 weeks for others. With these two criteria, the concept of routine induction at 39 weeks has come into picture. To add to this, there was a trial by name in Arrival trial in 2018 in USA. It's a huge trial of 6,000 pregnant mothers have been involved, 3,000 in each arm. It was stretched over, I think, 41 hospitals. That also supported the routine induction at 39 weeks, which tells about the reduction in the rate of cesarean section, reduced hospital stay, reduced neonatal complications, etc. But the thing is, the routine induction at 39 weeks should not be taken as a thumb rule. Because, once again, because of the two reasons. One is, so many times you may not know about the gestational age of the baby. Gestation period may not be known routinely. More than that, the brain maturity occurs mostly in the last few days and the last few weeks. The benefit of maturity of the neurological development, cerebellum, cerebral gyri and the sulci, these are all the development which occur around 39-40 weeks. If you routinely induce at 39 weeks, the baby will be handicapped with these benefits. So it's not good to induce routinely at 39 weeks. It's my opinion. Thank you.
Anybody else wants to?
Yeah, madam.
Yeah,
Shall
Suguna.
I, madam?
Yeah, Ramlika. After
Yeah,
you,
madam.
I'll
Actually,
speak. Yeah.
I'm in much in favor of inducing at 39, even 1 week maybe early also, 38-39 weeks. 38-39 weeks, because as I already told, the Indian baby they mature fast, and after 38-39 weeks, so going for fetal meconium stain, like these are very common. And also nowadays we plan for planned obstetric, planned delivery in a daytime. So because if you do stripping and send patient home, so they'll come in emergency with some complications. So now I think in my practice, especially in private setup, so all patients, especially primary or multi, so routinely at 38-39 weeks, what I'll do, planned obstetric, evening 6 o'clock, I'll do police catheter, and morning by 4 o'clock, 5 o'clock, most of the time catheter will be expelled. Even if it doesn't expel, we will remove it at 6 o'clock, maybe 10 to 12 hours. Then I'll put maybe 1 dose of misoprostol, 50 microgram. And majority, you believe me, most of the 70-80% of the patients they deliver in a daytime before 4 o'clock. 4 o'clock. And I don't use multiple misoprostol also. So with police, with one dose of misoprostol, maybe 50 microgram, not 25. And majority they deliver. And it is so comfortable. And earlier I used to do shipping and used to send home. And many times they used to come in fetal distress, rupture of membrane, cord collapse. All those problems used to be there. And always, many times we have to wake up in night. So from past 5-10 years with good monitoring and all, and hardly I wake up in night calls. So this is a really is working very wonderful for me. Yeah. Because
it's a very nice chair, Dr. Ramlingappa. I'm really happy that you are one of the experts today, and you're giving the courage for planned delivery through induction to
Actually,
our
just to tell program labor.
Only thing you have to do counseling.
Lot of counseling.
Patient have to counsel a lot.
Inadvertently.
Initially they were so reluctant, but now people are agreeing. And you have to explain them. If you wait, then the chance of fetal distress, meconium passage, all things will be more. Then definitely they'll agree. They'll agree. They'll listen. And it really works wonder, madam. Actually, even I got a statistics.
Thank you. So, that will be great, Ramlingappa. I think we look forward to a publication from you.
Ramlingappa sir.
Yes.
I have an objection regarding that. The technique of induction, whatever it told, we also follow. Unfavorable cervix, Foley's catheter, next day morning, 4th hourly or 6th hourly misoprostol. Yes, we do the routine in cases of whenever the Bishop score is quite less. But on the other hand, inducing around 37, 38 weeks, because
38, 39.
Okay. See, I think we have to back up with the daily fetal movement count, BPP, and CTG. I think we have to leave allow the pregnancy to go up to 40, I feel. Because with these three armamentarium, reduced fetal movement, if the patient is coming, the mother is coming with reduced fetal movement, I will agree. It should be supported with the induction. If the movements are pursued in a suitable way and implementation of biophysical profile and the CTG, I think we have to allow it up to 40 weeks with the reduced, with the bad BPP score, Bishop score, the techniques, the same thing, I also use the same. Sorry.
Correct. So that is good. It's good. Ramlingappa, can I speak? One moment. Let me just bring things into perspective, because I am very, very happy that you brought in the concept of combined method, because combined method, one mechanical and one pharmacological, may improve the outcome in terms of ripening and delivery, and many institutions do that, including ours. We also do combined, and we have a couple of theses also going on in the same direction. Now, what I wanted to say that today's product, which we have been discussing, probably will overcome the need for combination. It is possible that with one insert, we may be able to achieve what, the two methods were achieving. It is possible. I'm not saying, because there are no trials. So just let us bring it into perspective that so far there is no definite evidence that any one method is superior to the other, if we are discussing about methods. And regarding the gestational age, I think Dr. Durgadas has every right to take his patients to 40 weeks if he feels that is what works for him, because then he will get more patients coming in with spontaneous labor, which has, we all know that spontaneous labor has the best outcome. Whatever said and done, it has the best outcome. Now, the concept behind ARRIVE trial was principally the most important desirable outcome they were looking at was actually reduction in stillbirth. Because stillbirth today is a huge burden, and there is very little which has been done towards it. So this was thought to kind of, address one part of the problem at least. The other reasons, the other outcomes which have been seen, as Dr. Durgadas clearly said, very, very nicely he summarized it, there was reduction in the rate of cesarean section, especially, following induction. And I think that is something very desirable. And it was seen that in women in whom they waited up to 40 weeks, they were slightly higher. And I feel that is because the higher incidence of meconium staining was there. And sometimes obstetricians do not have the courage to wait for birth, even though everything is favorable once meconium is seen, even though the CTG may be normal, etc. Now, the other reason which he gave is also very valid, that we see less number of late onset hypertension whenever we deliver by 39 weeks, as well as the composite perinatal outcome, it is called. The composite, every, possible complication, neonatal complication is seen less when you deliver at 39 weeks in a very safe way. Of course, there are a little monetary benefits also, because whatever monitoring we are talking about in between 39 and 40 weeks, it really costs the family in terms of the visit, in terms of the test, etc. So now I look forward to what you have to add, Dr. Ramlingappa. Thank you.
Madam, actually up to 40 weeks, the chance of going for spontaneous labor is okay, madam. But after 40 weeks, no. So the going into spontaneous labor is less. But they have studied in some. It has come in RCOG. So once they go post-datism, then the chance of whatever we try, so success rate will be less, and also chance of meconium passage is less, and baby grows bigger. So chance of relative CPD, all those things will matter. So what I feel in our Indian scenario especially, so I think 38, 39 weeks is still ideal, and I think better, rather than expecting
I
some
think many
unexplained.
practitioners will agree with 39 completed, but they may not agree with 38. That is what I feel.
Yes.
In low risk gravida, we all
Not
agree
more
with
than
30
40 weeks.
Okay.
No post
Yeah,
No 40 weeks.
no post date is no post date.
Okay. Let us get ahead with the questions. Yeah, Rajeshri.
So, Dr. Rajeshri,
Should be individualized
the case for induction.
based
It's
on
not
patient.
a blanket
Yes.
statement that at 39 weeks we need to induce. I think we need to individualize the patient.
Individualize the patient.
Whether it's beneficial to deliver at 38 weeks or 39 weeks. I would like to quote here an example today itself, which happened in my hospital. This patient, second gravida with previous one abortion at 5 months, cervical encerclage was done. I removed the encerclage and induced her with Foley's catheter. Just like Ramlingappa sir's schedule, 6:30 evening Foley's was introduced. Morning by 6, 7 o'clock, she was 3 to 4 centimeters dilatation. She went in for a good contraction spontaneously, spontaneous rupture of membranes, and by 11:30 she delivered a 3.8 kg baby with shoulder dystocia. So this patient was induced at 38 weeks of gestation because it was a precious pregnancy one. And second, I felt that the baby size is big. So had we allowed her to go for some more duration of time, maybe 1 week or 10 days or so, she would have definitely had a cesarean section for CPD, and she would have landed up in meconium stained liquor. So I'm glad that I individualized my induction protocol based on the patient profile and the requirement. I did conduct a normal delivery for this patient.
No, with shoulder dystocia. It was not normal. Okay, good outcome, Rajeshri. Congratulations. But the only thing is, we don't want to give the message that macrosomia is a indication for induction of labor. Okay, but your outcome was excellent. Your outcome was,
we need to individualize the case definitely at 39 weeks, provided we have
can we quickly take a few more questions so that
Madam Rajeshri, madam, what do you prefer, mechanical or pharmacological method for ripening?
I said just now, mechanical is my first choice for the past 10 years now. We heard a lecture by Dr. V.P. Piley in one of the national conferences, wherein he very nicely put up how it is very dangerous to put the uterus to contraction without having proper effacement and dilatation, and also the various literatures which give us much evidence to say that it is useful to prime the cervix properly, and Foley's gives a very beautiful, smooth and effortless and harmless kind of effacement and dilatation. You just leave it for 10 to 12 hours overnight, and then it comes out very well. Previously, what we had like laminary attents and all, definitely we are not using them now. So mechanical dilatation by using a Foley's catheter, inflate the bulb with about 30 to 50 ml of saline, and just give a small pull to the Foley's catheter and strap it to the side of the thigh. Definitely
there is I must share, there is one, thank you, Rajeshri. There is one share by text by Dr. Madhubala, which I wanted to highlight because this experience has come to us also. She is writing, not everyone is fortunate enough to go into labor after Foley's. So I actually, share some of the experience with her, because we also find that Foley's, very often leads to reasonable opening of the cervix, but it does not lead to effacement. So contractions are a must for effacement, and probably in women whose uterus is very quiet, we do require a pharmacological agent. I
Yes.
think dinoprostone vaginal insert has a huge potential, and I think today's lecture has highlighted that it is safe. So, as you said, Rajeshri, in carefully individualized cases, maybe primies at 39 weeks, or even multigravida with one previous normal delivery, maybe it is better. Now, I just wanted to share, Suguna and Shobha, you give me just few seconds more
The
on this
question is
answer.
also there, madam.
Yeah,
Which pharmacological method is better?
And I will
No.
just share a little bit, then
Yeah,
other
yeah.
experts can come in.
Yeah.
We have had a study on this a couple of years back, and it was actually, we found that the incidence of cesarean section was less in this group. There were only some 50 odd cases in each arm against dinoprostone gel, the pessary versus the gel. But two things which kind of made us little worried were, one was that pain was more in this method, the requirement for analgesia. So it is important that before onset of active labor also, the woman experiences a little more pain when there is a DVI. So we picked up cues from there and we started giving better analgesia. We had a paracetamol trial running, so we saw that with because we don't want the woman to be very sedated so early in the priming process. So we used paracetamol to ease pain, intravenous paracetamol, and they did better. The other thing was, there is a slightly higher incidence of meconium staining as compared to the these were the two things. But definitely the response of the cervix was better. So I feel that this method is something which works better than the gel, because it's a surer drug delivery into the vagina, whereas the gel tends to get lost a little bit. And also it is less invasive, because see, I just wanted to tell the audience that there is actually a lot of need to use a method which does not go into the cervix. Like dinoprostone gel is considered invasive in NICE guideline. They say it's an invasive method because the woman experiences a lot of discomfort with the gel, but the pessary is in the vagina. So it is less invasive method, and therefore it will have less chances of hyperstimulation. It can be easily removed, as Dr. Kakkar said, and compared to misoprostol, the hyperstimulation incidence is less. So we must think of this as a very good alternative. That's what I have wanted. When you're choosing pharmacological method, keep in mind that we have an insert and it is worth trying out. But if you are more focused on mechanical, so be it. Yeah. Thank you for the time. Thank you.
Thank you, madam. Asha, you can hear me? Okay.
Yeah,
sir,
you can proceed with the question, I think.
Ramalingappa, sir. In your institution, do you feel there should be a written protocol for induction of labor? Ramalingappa, sir.
Can take the question. Others.
Rajeshwari, madam, can you take the question?
We will not wait. Yeah.
Yeah, I think each
Hello.
of the.
Yeah, he's there. He's there. Yeah,
madam, the last 6 months actually we have done SOPs and protocol for all obstetric problems, and the induction is one same already as spoken, and we have prepared the protocol for term, then PROM, preterm PROM, IUD, and previous section. All these scenario we have done SOPs, and initially one unit days to follow one method. But earlier it was mess only. There was gel was there was a lot of misuse gel. They used to put every 4 hours, 6 hours, 3 times, 4 times. Still we are unable to achieve the results. So that's why we have prepared now SOPs per term. It was already told 39-40 weeks. Same thing we are following. So with the mechanical, and morning will be either tablet or gel. So some unit they follow the mechanical method with gel. Some unit they follow Polish catheter with misoprostol. And once 3-4 centimeter dilatation, you do ARM. Then after ARM, usually start oxytocin, and majority they may deliver in a daytime. So this is for a term. And previous section, we have prepared the SOPs. So all previous section we put a same mechanical Polish catheter number 18. Then after 12 hours or 24 hours, then by the time if his catheter expelled, then we put we start syntocinon. For previous section, we have prepared the SOPs. And PROM, premature rupture of membrane. PROM also we have prepared SOPs. So those are already in labor, you augment the labor. Those are not in labor, you put antibiotics. Hello?
Yes, sir, you are audible, sir.
Yeah. And those are not in labor, we put antibiotics, then start induction at 37 weeks only, either with misoprostol or with oxytocin. And less than 37 weeks or more than 34 weeks. So usually the role of steroids may not be much effective. And usually we are in favor of again starting induction rather than waiting. We can wait maximum we can wait 24 hours. So most of the patients they may go in spontaneous labor between 34 to 37 weeks. But less than 34 weeks, so steroids and a short term of tocolytics, then antibiotics. So once 34 weeks, we will induce.
Yeah, I think you can proceed with the next question because we'll.
Yes.
Thank you so much, Dr. Ramlingappa.
No, I think to put it into a nutshell, it's divided into whether the cervix is favorable or unfavorable, whether the membrane is present or not. With the unfavorable cervix, mechanical method supported by either prostaglandins or oxytocin. Favorable cervix, you do ARM or and with oxytocin. With leaking membrane, oxytocin, prostaglandin is the first choice. In case you use oxytocin, ARM should be done at around 2 to 3 centimeters. Membrane, ruptured membrane, go for oxytocin or the prostaglandins. Stripping of the membrane is the basic criteria in all the criteria on all the protocols. Oxytocin should always be combined with the ARM.
Yeah.
This is the thing you can put in a nutshell.
Pre-induction rifling also can be done with RU4, maybe piston. 200 mg on OPD basis.
No, I have not used because I'm really scared about that. I have not used it.
IUD, yes. But we are
using
in one.
Yeah, IUDs we have used. Ribos I have not used.
So next question is was discussed by Shobha Madam just now. In mechanical agent versus pharmacological method, which newer method do you feel which is better? Rajeshri Palladi Madam?
Yeah, I think the highlight of today's
lecture
labor is to the point that, you know, the Cynapress or the vaginal insert is coming up and emerging as a choice of drug for induction of labor. And now it's pretty well, I think the good marketing is going on even in the tier 2 cities that the people are coming up with Cynapress, and it's time maybe we switch to this method of induction labor, because it has the definite added advantage of causing both the effacement and the dilatation in an unfavorable cervix. But then for those who wherein there is a shortcoming or where the unavailability of the Cynapress, like just Dr. Durgadas sir said, prostaglandins remain the choice, but it depends on what kind of misoprostol. It's still an off-label drug, but whether to be given orally or vaginally or sublingually or buccal. Oral seems to be having a better outcome in terms of causing less deeper stimulation and more consistent effort than the vaginal route or the buccal route or the sublingual route. And misoprostol, along with any kind of mechanical dilatation and augmenting syntocinon. Now, syntocinon, the drug which originally started for everything, still continues to remain the rescuer when it comes to, you know, having a proper outcome of labor. When all these methods are being used, syntocinon given in a good titrated dose and with proper monitoring and supervision, and to prevent stimulation, because with syntocinon we can have a control of how much contractions is going to take place, wherein
Immediately stop.
and the other drugs, we cannot have the control. Once inserted, it is there. But with syntocinon, we can have a proper smooth transition of contractions of the uterus and to stop when the contractions are more. And lot of literature on how to titrate the syntocinon, the mode of administration, how many units to be given, etc. So all these things put together and given a proper protocol, just as mentioned, that each unit should have a proper definition of how to start, how much to start, how to supervise, when to switch, when to call it off, and how the doses have to be repeated, and the maximum dose of each molecule which has to be repeated.
Yeah,
So
that is
monitor for the
very
maternal and the
comprehensive. That is, yeah.
Yes.
I think we'll go to the next question,
Yes, sir.
Suguna, please.
So,
Shobha?
Durgadas sir, post-ripening induction, what is your discussion on oxytocin drip, its dosage versus misoprostol? Ripen cervix, sir.
Ripen cervix? What's it?
Oxytocin drip versus misoprostol.
With no, pass it on. Ramlapa sir.
Ramlapa sir.
Yes.
Madam, post ripening. So
how to augment the labor?
Yeah. Already those are in already past latent phase. Active labor, 3-4 centimeter dilatation. Always you do ARM, then see the LICA color, and you can roll out meconium passage. If LICA is clear, pelvis, if it is adequate, then usually you start oxytocin.
Oxytocin
So
only is the standard.
Oxytocin, here is again method, whether arithmetic or geometric method. What we follow is usually, practically speaking, we don't have any infusion pump. So your normal dip only we put oxytocin.
I think see Ramlingappa. I think infusion pump doesn't cost that much.
Yeah, madam.
And I think we should upgrade. Most often we don't get these things because we don't kind of exercise that will.
Yes,
most practitioners will be able to afford an infusion pump. And I think that is the standard of because so many times mishaps will happen and hyperstimulation happens because of that and not because of the drug, right? So better to have an infusion pump.
Coming to the preparation of oxytocin.
The question came because I had posted the question because see, sometimes we use misoprostol as a ripening agent, right? And with that, the woman gets into active labor. And then the labor is so propulsive at that time that they don't need the oxytocin. They deliver with miso only. So I wanted to give a message that oxytocin is not always needed because there is a lot of tendency for practitioners to just start the drip anyhow. So it's important to, if the woman is progressing well, we need not give an oxytocin drip. Only hydrate her well and give her analgesia and allow her to deliver. So many times when we use misoprostol and even when we use the DVI, the dinoprostone vaginal insert, sometimes the contractions established are so good that only artificial rupture of membrane is needed. Syntocinon is not needed. And then you can do the AMTSL. Okay.
One minute. About these things, one thing about misoprostol. Once you use misoprostol and the patient has gone into uterine contractions, after that, stop giving subsequent doses. Number one, because things are not in your control, it may go into hyperstimulation. Number one. Second thing, with respect to oxytocin should be given in an infusion pump. Fetal heart monitoring is a must. And as rightly told, ARM should be done. And I think you want me to tell the dose of oxytocin? You want? Shobha, you want me to tell me the dose of oxytocin what we use? The two doses, low dose and high dose.
High dose is that.
Okay. Low dose is 0.5 to 2 milliequivalent and high dose is 3 to 6 milliequivalent per minute. That is, if you add 1 ampule is 5 unit, add 1 ampule of that 5 unit in 500 ml ringer lactate, use an infusion pump, 6 ml per hour denotes 1 unit. 6 ml, 5 units, 1 ampule of oxytocin in 500 ml RL, 6 ml of it denotes 1 ml. So now you choose whether you want to have your low dose or high dose of oxytocin. Accordingly, and it should be it should be titrated once in 30 minutes. Not early. Ideally, it should be titrated up to 30 minutes and should not go beyond 20 units per 20 milli international units. One thing I want to tell you: once you use misoprostol, if you want to switch over to oxytocin, take 4 hours. If you use dinoprostol, take 6 hours. If you use the tape, I think, Shobha, it's just how long? It's half an hour? Half an hour?
24
Yeah,
hours.
yeah. Once, correct. Once
Half
we
an hour.
remove, after that,
Half an
after half an hour to 1 hour, we can assess and we can start. Yeah.
Only one thing I want to make it very clear: once you have used misoprostol, if the uterine contractions has been established, don't repeat the further doses. If you want,
That's
take
a
the
very clear
assistance.
message. Thank you.
Yes.
Very
They go for
clear
uterine
message.
rupture.
Thank you.
Yes.
Thank you.
Next question, Rajeshwari Madam. Discuss maternal and fetal monitoring in induction of labor.
Basically, when we have admitted the patient, that we need to evaluate all the vitals of the patient and do a mandatory NST to know whether the fetal heartbeat is reassuring or not. And then the progress of the labor, once we have set in for the induction of labor, try to maintain a chart, that is a partogram chart, to see the progress of the labor and all the important parameters of the maternal, like the pulse rate, the the blood pressure, and watch for the PV bleeding, especially so when we are suspecting a high-risk pregnancy patient or induction of labor in a previous cesarean section, because variation in the pulse rate and the bleeding will be the first warning signs and symptoms of having an impending rupture of the uterus. So all these basic parameters to be noted down. And one thing is that before induction of labor, suppose we plan to put maybe the Cerviprime gel. I would like to ask from the audience whether we would like to insert the Cerviprime and send the patient home or keep her in the hospital. I personally feel that keep the patient in the hospital when we make a decision to use the labor should be the dictum, because just now Dr. Kakkar said that maybe the OPD basis of
outpatient induction. Yeah.
But still,
whether there is any role of outpatient induction.
I actually brought up this
in low risk gravida.
Although we don't practice it, but then I want to reinforce the point that please do not resort to inserting or putting in some medication. Even some patients, some practitioners, they just insert misoprostol and send the patient home and ask them to.
There is good discussion also in some studies about outpatient induction. I think given the litigation scenario in India right now, obstetricians are a very vulnerable group, and probably as far as pharmacological methods are concerned, better not to. There are some studies which say that introducing the Foleys and taping it up, especially the double cervical balloon which has come now, and sending them home and calling them after 12 to 24 hours, provided the woman stays close to the hospital, will reduce 1 day admission to the hospital. That is the logic behind that. Well, can be done in a very well-controlled situation, but definitely not as a rule. So probably from this webinar, we must give the message that right now we are not discussing about outpatient induction. That was a good message, Rajeshri. Yeah. We'll proceed with the question on failed induction, Suguna, because I think we'll run out of time, and after that take the concluding message.
Ramlingappa sir, can you speak on failed induction?
When do we define as failed induction, and what is failed induction? Is it failure to deliver or failure to get into active labor? What exactly it is?
Durga Das sir, can you take the question? I think he did not hear. How to define failed induction?
If we cannot achieve cervical dilatation of around 3 to 4 centimeters, even after 12 hours after using oxytocin drip,
what about gel, sir?
Any technique, or 24 hours, if you cannot deliver the patient by 24 to 48 hours, then it's called failed induction. It's mainly the cervical dilatation is taken into consideration.
I think we should also consider that even after inserting the cerviprime gel for 3 times and wait for 24 to 48 hours, if she doesn't respond, then that would be a failed induction. But it doesn't necessarily mean that we have to give up on the induction. She can be recounseled again, reassess again, and again we can go for some alternative or combination method of induction of labor. So by using the misoprostol, although it is off-label, and some of the states are still not authorized to use the misoprostol as a induction of labor, like in South India, some states we have Tamil Nadu, Kerala, etc. But some states we are resorting to using the misoprostol as an off-label application of misoprostol. So when we have given misoprostol about, the dosage being about 6 tablets, or reinsertion of cerviprime, or 1 Synapres for 24 hours, or Syntocinon.
Propress, it's not Synapres, it's Propress.
Sorry, Propress, yes. Propress, then we
Synapres is contraceptive.
You
It's
know
Propress,
it better.
Rajeshri.
You get the message. You get the message that it is Propress, although we have to call it as a Dinoprust, what we technically
vaginal insert, DVI, we call it
vaginal
DVI.
insert.
Yeah.
So these are the things that we have to keep in mind, that
Correct.
having used them for such period of time, then we call it as a failed induction.
I just wanted to add a little bit here about failed induction is, I think we should not give up easily. That is one message which I wanted to give, because primarily when you have established the induction indication, you have committed yourself, one has committed oneself to delivering the woman vaginally, yes. And also one is sure that induction is not harmful for the mother or the baby. That is why we have taken it up. So there are very, very few, situations where a new kind of contraindication will crop up suddenly, or a new risk factor will come up suddenly. So when we say that 24 to 48 hours, it becomes a very wide interval. We have to give a clear message whether it is 24 hours or 48. So ACOG recommendation right now, which everyone is feeling that they should follow that now. I don't know how much practically it is possible. It clearly says that it should be both ruptured membranes and oxytocin. It has to be post rupture of membranes, a duration of 12 to 18 hours of oxytocin infusion. So the message that ACOG has given, or the directive it has given, is this does not have to do with cervical ripening. So what I'm trying to say is failure to achieve cervical ripening does not equate to failure of induction. I hope the experts will agree with me. Failure to achieve ripening of cervix does not equate with failure of induction of labor.
That means you can again do induction
That's
of labor
what
at a later
Rajeshri
stage.
also was trying to say. Rajeshri also was essentially trying to say the same thing. I wish Dr. Ashwin would be there so that we can ask him about failed induction. I was very keen to ask him about failed induction. So I'm asking him to unmute, and I'm wanting to see if he's still available. So far he has not unmuted, so he may not be available. So when we read the entire literature on induction of labor, it does look like cervical ripening failure is not failure of induction. There are many times when the family becomes upset. When we go on trying, they become upset and they say, doctor, you have tried enough. We have seen you struggle for 2 days now, and none of the methods that you used have worked. And you are saying that you have used all the scientifically proven methods. Please go ahead with cesarean. So, and the woman also will start asking. And we have been always told that we cannot go against the woman's autonomy, and we label it as failed induction. So probably we must see that we give the proper indication when we do a cesarean like that. So I hope the experts are on board with this, and we must bring into perspective the ACOG guideline of 2024, which says that after rupturing the membranes, that means for rupture of membranes, the cervix should be at least 4 to 5 centimeters dilated with the head nicely sitting inside the pelvis to -2 to -1. We cannot do before that. So that means that the labor has progressed till there. And after this, the oxytocin infusion has gone on for 12 hours. And then only it is failed induction, when there is absolutely no chance of vaginal birth. So that was the message which I wanted to bring up. What do you say? All of you give your concluding messages, and I think it will be time to wind up. Yeah, thank you so much. Yeah.
Experts? Sir Ramalingappa, sir. Concluding message.
Hello, madam. After doing ARM only, we can conclude failed induction 12 hours. 12 hours, not really 24 hours. And again, waiting and restarting induction, really, I don't know. At present day, it works because you have to do a lot of counseling to the patient and patient attenders. They may not be willing. So as Shobha madam rightly said, so I am the same opinion. After ARM, 12 hours maximum.
Rajeshwari madam has told her opinion. She told Durgadas sir.
Conclusion about the sir today's.
Today's.
Yeah. No, I'm really waiting for the DVI tape because though I have used the same protocol as Dr. Ramalingappa has told, Foley's catheter and misoprostol, I had lots of times I had unfavorable service continue and landing up in cesarean section. Yes. Looking at Dr. Ashwini Kakkar's statistics, such a reduction in the number of cesarean sections, I am eagerly waiting to use that. Thank you, Dr. Shobha, for this opportunity.
Madam, one more thing. Madam, one more thing.
Yes,
hello?
Sir. Yes, sir.
Madam, actually, when prostaglandin gel came, in probably 95, I did a first thesis on PG2 gel. Actually, initial results were very, very excellent. Only with one application. Majority, they go into labor as well as rifling as well as inducing agent. So only in few cases you used to use oxytocin actually. But of late, later, the effectiveness, I don't know whether the company people, they should tell. And
I think even Dr. Suman shared that her experience with dinoprostone is very good. That's what she also shared.
Maybe logistic problem. They are not kept in the fridge.
Yeah,
during transport. Maybe a logistic problem.
That may be, now, three applications, still then patient, many times they will not deliver. So when initially it was really very effective. This is my practical experience. I don't know with the DVI also same. So probably I think we have to wait and see how it works. Because initially when PG2 gel was introduced, strictly should be intracervical and should have a local effect rather than systemic effects. So because if it's gel spill into the posterior or into the cavity, patient will have more of systemic effects. So chances of fetal distress were very, very high. So I don't know whether the same thing applicable to DVI because we are putting in a vaginal. So it will have more systemic effects. So probably I think we have to wait and see, and we have to see our personal experience.
I think the refrigeration is important. That is,
I was about to say that it has to be kept at -10 to -25 degrees.
25 degrees.
We decide to use the ProPress. So I think this strict vigilant maintenance of the cold chain, be it either the Serviprime gel or the ProPress, is going to be very mandatory to have a very good effect. So this shortcoming is overcome by misoprostol, which is so much very friendly for the clinicians and for yes. I think we had a very, very useful and interactive exchange of ideas regarding the induction of labor, because once we commit to induction of labor, it's the ticking time, and it's the time we are race against the time, and all of us are really prepared for that. We have committed into something, and I think it will become a norm in the future years that we make a conscious decision to induce the patient to have a very good and safe outcome, and especially our main motto being to reduce the number of cesarean deliveries.
Primary cesarean.
Primary cesarean. Yeah, that's a good message, Ramalingappa. Primary. Thank you, Rajeshri. Just wanted to add.
We may get the foods after 5 years. If you get a primary section, then we may get to start getting food maybe after 4 or 5 years probably.
Yes.
So one more thing. One thing, one question. What is the incidence of postpartum hemorrhage after induction of labor?
That's what I was coming to, Suguna. Yes. That the exact indication after induction is not known, but one thing is definitely known that the
Mm.
incidence is higher.
High.
And
It
higher. And yes,
Mm.
yes. And it is
Mm.
irrespective of which method has been used and how long the labor has been. And whenever there is artificial initiation of contractions, the uterus acts more. So my experience is both labor analgesia requirement is more, and that means it's more painful than natural onset. One thing. Second thing is the incidence of atonic PPH in particular is more. So we need to be kind of forewarned and forearmed. And ideally speaking, the complications of induction of labor must be discussed with the woman in the family before we undertake it. So the consent form should feature the possibility of these kind of situations wherein, and then also the reassurance that we will be kind of ready to deal with all of it. So that is what I wanted to tell in the end.
I think
One thing-
oxytocin drip should be continued for further two hours after
the
delivery.
fourth stage, the fourth stage should be managed better. Very, very, very useful.
Yes.
I think with
So,
that, yes, Suguna. I
Yes,
must
we are
thank
going to
Suguna
conclude.
really for conducting the whole session so very well, and Shobha also, Shobha Shavi also. She is actually in a wedding and she kind of made it a point. So, Rajeshri,
Her
before you
connectivity is
give the
not
vote
good.
of thanks, I will just request the person from Ferring here, the champion for this, the pharmaceutical company which is championing the cause of safe labor for women with this product, right? Sharvari, if you want to say anything, you can say Sharvari and your colleague.
From our side,
what is the
we
cost
want to thank Shobha Gudi for this excellent program.
Thank you very
Really,
much. Thank
yes,
you.
and all the panelists, my co-panelists, thank you very much.
Thank you, madam. Thank you all.
So we have Dr. Deepika from our medical advisor from Ferring. She will give the vote of thanks.
So thank you so much to all the esteemed faculty and speakers here today who have really enlightened us with not just the induction of labor, the time period that when it should be induced, what should be taken into consideration, apart from the modified Bishop score, what all should be taken into consideration. We had such a healthy discussion on that, and also all the pharmacological and non-pharmacological methods. I think after this insightful session, there will be more confidence in managing the patient, managing the pregnant lady with induction of labor, and more so we are hoping with our DVI. So thank you so much for this, and good day to all of you all. Thank you.
Thank you.
Yeah, and special thanks to Dr. Kakkar for giving the talk.
Yeah, I think sir is
Sir is not here, I think.
Okay.
Shobha madam, you have to unmute actually.
Thank you so much, madam. Thank you.
Thank you.
Ashwin, you
I
are
thank
there.
all the experts.
Yeah.
Yes,
for
I'm
your
very much
good
there, madam.
opinion.
Yeah.
Yes, madam.
So your thoughts on failed induction? When do you call it failed induction? Yeah. The audience
I
are
would
waiting
wait.
to hear.
Okay. I would wait for 24 hours after the whatever method I've induced. And if absolutely no change in the cervical score, and if my patient is willing, I wait for more 24 hours and then reinduce her.
That's
But
what.
that's if the patient is willing. Most of the time, the patients are not willing nowadays, madam. Most of the time.
No, but we are very kind of actually a little surprised and delighted that with induction of labor so proactively being taken by you, you have achieved a low cesarean section rate. And that is why we are really delighted that you have shared your experience.
Thank you so much, madam. Thank you.
Okay. Thank you. So it's time to end. So I think Arun, you can stop. Thanks everyone. Thanks in particular. This was very rewarding.
Thank Shobha Gudi madam for giving me this opportunity, and also I thank all the experts for their opinion.
Thank you.
Thank you.